I'm Michael Lanuti. I'm one of the thoracic surgeons at Massachusetts General Hospital in Boston, Massachusetts. Um, I'm in a rather large division of thoracic surgeons, and I'm the director of thoracic oncology for our division. I have clinical interest in lung cancer, esophageal cancer, mesothelioma, and I also have a translational lab that looks at novel treatments of lung cancer. What is the current standard of care for superior sulcus tumors? Let's first define that. So the superior sulcus is at the very apex of the chest, and tumors can involve the bony chest wall of the chest. They can involve the brachial plexus, and as well as the subclavian artery or vein. And so they can be on the anterior part of the superior sulcus, or they could be in the posterior part where they're closer to the spine and invade the spine. These tumors are otherwise known as Pancoast tumors, and they have a unique management with some randomized, well, not a lot of randomized studies, although some good studies that go back a number of years that showed that a multimodality approach, including chemotherapy, radiation, and surgery, can provide good outcomes and good survival. Since you would say, why can't a surgeon just remove it? The answer is that we can't really achieve an R0 resection when the tumor is sort of touching all those structures that I mentioned, because you can't remove all of them. That is, the brachial plexus would give you arm disability. Removing the vessels, that is the subclavian artery and vein. So we actually can do that and reconstruct them, and that's been an evolving part of the surgery for this operation in centers of excellence. So we rely on induction chemotherapy and radiation followed by surgery, so that we can, if we're going to expect a possible R1 resection or less than complete, at least there's been some local control of the disease outside of surgery. So induction chemoradiotherapy is the standard of care for operable patients. So what do we define as an operable patient? So one is that the tumor is not extending deeply into the brachial plexus. It's not completely encasing the entire subclavian artery, because that would be very difficult. And in addition, the ideal patient is a patient that doesn't have mediastinal lymph node metastases. So the patients have to get a rigorous workup with brain imaging, PET scan, and then invasive mediastinal staging once again. And we're looking for ruling out N2 disease, because we know that those patients do not do well even with surgery. And then there's always this, what do you do with the N1 disease, the gray zone? Would a surgeon decline a superior sulcus tumor with an N1 hilar node? And the answer is it's a relative contraindication, but there are patients who can achieve a reasonable outcome with N1 disease. It's certainly not as good as N0 disease. Again, if the tumors are in proximity to the brachial plexus or the subclavian vessels, it's the judgment of the surgeon to render resectability. And as I mentioned, the subclavian artery can be resected and reconstructed. There are some increased complications with that, but it can be achieved. Invasion into brachial plexus is a clear contraindication to surgery. Determine resectability, the surgeon often relies on the imaging, and I think CAT scan with contrast is not as good at looking at soft tissues of brachial plexus. And so in these cases, we will often employ an MRI, as you suggested, or to really understand the invasion in that area and help us determine, is it resectable or not?
I guess, do you think, so the reason that we manage these patients differently Do you think it ultimately comes down to the ability to achieve an R0 resection relative to other lung cancers?
Yeah, I think the reason that this particular tumor and tumor location has moved into a multimodality setting is that surgeon can't often, completely achieve an R0 resection. And so we really want modalities to shrink the tumor and/or kind of treat the surrounding tissue to reduce the risk of a local recurrence.